even though we're not all here. It's certainly better than it has been for the last few meetings. So I'll go ahead and call the meeting to order. And BJ, if you would lead us in prayer.
Bow your heads with me. Our God and our Creator, we thank you for this day, for this and every opportunity that you give for us to share together. We say thank you. We thank you for continuing to bless our community amidst this pandemic. And we do ask that you will lead and guide and direct all that we will say and do this evening, that it might be pleasing in you.
Amen. So does everybody have the agenda with them or before them? Are there any questions about it or comments?
Move we adopt the agenda.
Second.
Okay. And the February 16th minutes, are there any changes for those? Any discussion?
I move we approve minutes as they've been presented.
A second?
Second.
Okay. So moved. Anybody for public comment tonight? No? Okay. So we'll start with the administrative reports. Tim, are you in first?
Yes, ma'am.
Okay.
We'll go to the financial update and then a little bit about the budget. I got somebody text me said they can't hear us.
Where's the microphone?
Tim, can you?
Okay, good evening. This is the financial update as of March 31st, 2021. If you, once again, this is a requirement for accreditation for us to know the 10 essential public health services and the functions of the health department. Anytime we make financial decisions, the board is supposed to consider these 10 functions. So you'll hear me say that over and over again because the accreditation says I have to say that, okay? The next screen. This is the expenditures as of March 31st. We should be at 75% spent, and we are currently at, where is it about? I think it's 62.1%, which means we are currently about 13% under budget and expenditures. So any questions? Okay, the next screen will be the revenues for as of March 31st, 2021. Once again, for each program, we should be at 75% collected. We are not at that number. We're only at 61% collected, so we're about 13%, 12%. Well, my numbers have gone in my head, sorry. 13% off from that number. But once again, we're under budget on expenses and we're under budget on revenue collection, so it's going to equal out at this point in time. Any questions on that? Okay. And the next screen will just show us where we are now compared to where we've been the past 2 years at this time. As you can see, this current year is in the purple, last year is in the green, and the year of 19 is in the blue. As you can see, immunizations and family planning. Last year was a really good year for our health department. It was probably the best year since I've been here. We had 2 providers, and clinics were running back to back to back, and we were making a lot of, we were making some money and getting in some revenues. This year, of course, the clinics have had to come back some because 2 days a week we're doing COVID clinic, vaccine clinic. So that's kind of dropped our numbers down just a tad. Any questions? Okay. Any questions?
No.
Okay.
You're explaining everything we need to know.
Okay. So the next little piece, we're gonna talk about right here, and this is just a draft. These are the numbers that we are actually turning into Kevin. Now, once it gets to Kevin and the commissioners, of course, they'll have their budget meeting and then they'll, come back and, say whether or not they accept our budget. But this is basically our draft budget. So, just a little bit of the summary here. We, are requesting 3 new positions, which you will see later on the agenda where we have those, and we'll explain those a little later and when they come up. Rollover COVID funding, as you will see also later on your agenda, we have almost over $400,000 in COVID money still left out there to spend. $200,000 for vaccine and about $200,000 for the tracing that we have not been able to spend because there's been no contact tracing, but we're working on spending it, but there's no way we'll spend it by the end of May. So
There has
they're,
been contact tracing, we just haven't had to pay for it.
yes, we haven't had
The
to pay
state
for it.
has been providing it for us.
So does the money go away May the 1st, May the 30th?
They told us that it would roll over until next year's budget. So it will be there next year. And we're finding different ways to spend it, and Mr. Caldwell can speak on that.
We're still working on it. So, and I didn't include that in this report because I wanted to include that in the following report. So the health department now is creating a county-wide task force. So the task force is going to come together. So we have, under my direction, we have set up a task force that include the school system, Starter County Health System, and then I asked the commissioner to also set on a task force. So what a task force is going to do is to collaborate, to come up with ideas on how we can be able to serve minority people, underserved community. So the task force is going to come up with idea on how we can be able to use the COVID-19 funds. So the email went out today, so to members who are going to serve on a task force, and they are going to come up with ideas on how we can be able to utilize that. So the task force is going to be ready by the end of this month. And we are going to be holding town hall because my plan is to be able to go like Laurie Hill, Wagram, Gibson. Last week, I went all around those places to do assessment. I did assessment and I figured out the task force was the best way to do and hold town hall. So that is coming up. I didn't add that because I wanted to be the guy. So that is coming pretty soon.
And also, please note that when it comes to COVID funding, there are strict rules on what we can spend it on and what you cannot spend it on. We'd love to be able to spend it on what we would like to, but
That was my question. Are there, it is, so it is.
there are restrictions, yes.
Yeah. Yeah, and in addition to that, just today, I got an alert from the health from the health department that we had a negative alert in the county that there's a vaccine hesitancy here. So they are asking me, based on the GIS system, to work on that. And I think I talked to Tim there about that. So I'm going to be working to see if I can hire some community health worker to work on the vaccine hesitancy part because we get a negative alert today, and that's not good. So I have to put plan into work to see how we can be able to get rid of that negative alert for the county.
And these funds can be used for those community workers to go out and push the vaccine and push the safety of COVID and stuff. So.
Sounds good.
Next thing is storage solutions. We have no space at the health department. So we're trying to look at different types of way of storage. We do have a shipping freight container, I guess that's what it is. But it's almost full. And we do have some things that actually need to be in, they can't be left out in there in the heat. They're like car seats and pack and plays that are for patients that we got to find some way to have some kind of temperature controlled storage unit. So we're trying to figure that. That's I planned that in the budget as well. Medicaid transformation. If you've heard about that, that's like the biggest bear ever. It's very scary to us because we don't know what's gonna happen. Basically, North Carolina has taken their Medicaid and pretty much privatized it, so.
Yeah.
And there's 5, I think they just added a 6th company.
2 years later, they're gonna go.
Yeah, 2 years later, after they pushed us really hard to get it done, and then 2 years later, they let it go, and all of a sudden they're saying you need to do it by July 1st. So here we are in April. We'll just do the best. We're going to be doing the best we can. We are trying to figure out how to make that happen. Any questions on that? Okay.
I do have a question about the storage.
Mhm.
You mean we don't have a place at the facility or?
Every office currently in our building either houses a person or houses some type of storage. We have no empty offices at this time. Now, those offices can be empty if we found somewhere to put the storage.
Yeah, no, we have large, because of COVID, and we have, through some of our budgets, we get car seats, which are large and take up a lot of space. And we would give them as incentives for, pairing classes. And we haven't been able to do that in 2020. So we have an extra stock of them now because we were not able to give them out. So, and it's time to get more of them in. So we're probably gonna have some sort of a health fair at some point to try to
Move some of it.
get
Maybe
rid
some
of
of
those
those car
car
seats.
seats.
Because they do expire.
But if we give them, we have to install them for everyone who receives one. We can't just hand it to them and let them pull it out of the parking lot.
That's right.
Car seats expire.
Yes, sir.
Yeah,
That's
Yeah.
ridiculous.
About 3 or 4 year.
So what about, does the county have any storage that the health department could use?
It's a pizza place.
I have not, as far as I'm understanding, I've not heard that they do. Now, it's a question I could ask.
it's some sort of warehouse or something.
But the thing is,
Storefronts.
Huh?
With all the storefronts around here, there ought to be some space you could rent. It's got air conditioning, you know.
Well, you said you were gonna discuss a plan.
yes, that's just, we're gonna come up with a plan to try to figure out how to get the storage done. We had the same issue DSS has. DSS has no offices. They took offices and put them in half and made 2 offices out of. They've done so much construction over there,
Yeah,
making offices for scats and transportation. So
yeah.
it's a building problem. There's just no room in that building. It's with 40-some people 40-some employees on our side, and DSS has over 100. That building is just not capable of.
So you say we need to do some construction? I'm kidding.
I would love to do some construction.
I know.
I would love a new building, but we don't go there.
All right, well,
But yeah, right, that story. And, anybody questions on that? Any more of that? I'm sorry. I don't mean to take up so much time.
you're good.
Okay, and this here is what I just talked about, the 3 positions that you see at the bottom. I won't get into any of that right now. Mr. Caldwell will go over that when he gets down to the, on that part of the agenda. These are the expenses. You can go and pass that one, and get to the graph if you don't mind. 'Cause that's probably the graphs, yeah. Okay, here's our submitted budget, which is, 3.9 million. As you can see, last year it was 3.8. Okay, so our budget's a little more this year. Granted, the positions you just saw sitting up there, which add to that. So as you can see, over the last few years, our budget has gradually gone up because we are doing more things at the health department than we were in the past. So the next one. These are our revenues, our projected revenues. As you can see, our projected revenues have gone up over the past several years as well. At 1.9, we're a little bit higher than what we have projected last year. And the reason that is I'm not sure when the clinic will get back to flowing the way it's supposed to flow because of COVID.
That's true.
If we're still doing COVID 2 days a week, then it's going to affect our numbers in the other clinics. And this just gives you an idea where our money comes from in the health department. The county makes up 51% of our budget. Federal grants make up 29%, Medicaid makes up 17%, and other fees and services make up 3% of our revenues. Our job as the health department is to make the purple go down lower. I have seen the purple down as low as 45% before. but it just depends on various factors. The less money the county puts into the health department, the better the citizen, the happier the citizens should be.
So what was it last year?
It was around 49.
49?
We always hover around the 49.50 mark pretty much every year.
So Medicaid is most of your provider work. When somebody sees somebody in the clinic, they can bill Medicaid.
Correct.
But you rarely get commercial. You sometimes get Medicare maybe.
Medicare, we currently, and we'll maybe talk about that a little bit later, we currently have only about 3 or 4 insurances that we're credentialed with, because most insurance companies will not credential with the health department. They don't consider us providers. Don't know why, but that's what that 3% makes up.
And if we can get a grant writer, we could turn that purple into blue.
Yes.
We are working on that because we've been reviewing all the reviewing all the programs to see which one is revenue driving and which one is not. So the ones that are revenue driving, we are going to invest more in it. The ones that are not revenue driving, then we are going to improve on it. And then I didn't mean to take 10 times, but then we introduced the idea of having the grant writing positions, because there are other areas that we can be able to generate funds with the grant writing positions. And down the line, you will see why there's the importance of having a grant writing position.
Any other questions on that? And the last one, screen. This lets you know how much money the county is actually putting into this budget that we've made. So that is the expenses minus the revenues that are not county driven, which is $1.9 million, or equivalent to about 9 cents on the tax rate. So if the county's tax rate is $1, 9 cents of that tax rate provides services for the health department. Any questions? And because it's accreditation, you got discussion, you're gonna have that, yeah. Accreditation says I can't just present it, y'all have to discuss it. And y'all did, so. We good? All right. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Tim. And the monthly activity summary.
Yeah, that I'll just chat a little bit about that, and that's the activity summary for February and March, and the report is there, and as the graph showing, you can see in that those are just summary there on the dashboard there, and you can move, yeah. And pretty much this has been my schedule. It's not exhausted, but we try to kind of show just a little bit of it. And on the right-hand side, you can see the highlights of COVID. Vaccines are now available for 18 years for Moderna and 16 years for Pfizer. And I think the nursing director, Dana, will talk more about that. And the health department has continued to provide guidance, separate CDC and the health department guidance for the school system. And also, we have been working with the health educators to continue to provide mass education in the county in reference to the vaccination and vaccine safety, because that has been a problem, misunderstanding about the vaccine. So the health education team has done a very good job working so hard to create mass education and try to work in that direction. And also the level of community transmission, and I actually did bring this package, and I'm going to handle this. The level of community transmission here is a little bit high, but maybe Donna can talk about that a little bit more. And I've been asking people to still continue to practice public health measure on that, because we still see the community transmission on that. And on the left-hand side of the screen, this is just my schedule, and I had a kind of training with Robertson County Health Director Bill Smith. We kind of trying to collaborate on things that will be going on in both health departments. Last week, me and myself had a conversation on some collaboration efforts that will be coming up soon. And also the health educator, Catholic Cox, and myself, and Jana and myself, we've been trying to do education appear on radio to educate the public about the COVID vaccine and preventative measures. I've also been in collaboration with the superintendent, the grant, in terms of the COVID, because we know the school has also been having some difficulties with the virus. We also plan on collaboration, and also with Greg from Scholar Health System. And we also talk about collaboration, and that's what I was saying with the forming the COVID-19 task force, which is going to be a county-wide task force. It's a collaborative effort that I want to see in the county, that people come together and bring ideas of how we can serve the county and kind of minimize the spread of the virus. Because when I came in the county, I set a target that I want to see 60% of the population hit a target to get a vaccine by the end of the year. And we can achieve that alone unless we collaborate with other stakeholders. And also attending all of the board meetings. So that's just that, and I would honor that if you will see that. Move on to the next one. And the goal for the health department in the next 5 years, I want to see the health department to double its budget from where it is. And then my plan for the health department is to have its own Ryan White and infectious disease clinic, to have a standalone Ryan White instead of having to sub grant from Robertson or Dogwood. So I want the health department to have its own Ryan White program, a Part B program, so we can be able to stay alone in the health department. So in order to do that, I put in for 3 positions. One is the as things show on the screen there, the grant writing position, the IT position, and then the administrative position. And the grant writing position we're still developing the job descriptions for that, so that wasn't added on the list here. But that's the goal for the next 5 years, to be able to double the budget for the health department, and for the Ryan White Clinic, to develop the Ryan White Clinic for the health department. I think so far that's it from my end, unless there's no questions for me.
Any questions?
So the Ryan White thing, it serves HIV,
Yes.
it's a volume thing, isn't it? I mean, do we have enough volume, or are we going to pull people from other counties, or?
We were currently contracting with, RHCC, Robertson Health Corporation. That's what and we called it our EIC clinic, Early Intervention Clinic. And so they basically they received federal money, and they let us have patients and paid us to see those patients in our health department, basically. So our contract ended with them because they want their community health clinic across from the hospital. They wanted to see all the patients there and not see them at the health department anymore. But our PA and our nurse practitioner were the ones seeing them. We probably have about 37 HIV positive patients in our clinic right now. So we contracted with Dogwood, which is Robertson County Health Department. They get state Ryan White funds. So we could also get that. It's just we have to apply for it when the application period opens. So we missed that this year, but that is the goal. And I gave a presentation on the PrEP program, pre-exposure prophylaxis, that we wanted to do in the health department, and COVID hit. And I never even got to take it to the commissioners. So that's another part of the, reducing that HIV. Because with our small numbers in our county, we have some more numbers of HIV and AIDS than we should. So that's our goal, is to try to get our own Ryan White money And also that grant writer position would help with that and with prep programs to prevent HIV.
The three new positions that you requested, Mr. Caldwell, the administrator, the grant writer, and I think the computing support technician. Is that correct?
Yes,
What is the total budget on those three positions?
I think they,
On the previous screen,
it's
I think it's 139.
Yep.
Is that right?
And are those funds accounted for through county dollars or state allocations or?
I think I talk more about that, but with the grant writing position, so this is what happened with the Ryan White. When we start with the Ryan White, I know there are a lot of federal grants for the Ryan White. The grant in the coming future, the Ryan White position is going to pay for itself. The grant writing positions, whenever you get federal money for the Ryan White programs, so that pays for itself. That can take care of itself. But initially, I think they can talk more about that on how we can be able to pay for that one initially. But then when it go, I came from Ryan White. I came from being paid with grant money. That's what I have been living with all my life. So when you get a grant, that's what you can pay for. So that can actually, it couldn't be county money, it can be for the grant. So going down the road, that person pay would come from the grant.
Eventually.
Yeah. And it is, and that grant writing position, because there are other programs in the health department, like for example, the health education area, maternal child health, or even prevention of using the tobacco area or behavior area. There are a lot of areas that the grant writer can use to secure grant money from. So it's not just going to be entirely Ryan White. There are other areas that we can be able to apply for grant using the same position.
And once we receive the grant, someone has to administer the grant, and that person would be the person administering the grant. So therefore, their salary would be paid from.
Eventually, got you.
Yeah, from the
And
grant.
the IT support personnel, how about that? I mean, will that person work under the county IT department, or is this just a separate IT person?
This was planned to mainly for a couple of things, our EMR system, our electronic medical record system. Currently, we have one of my staff who is a process system who does accounts receivable and collections. She is actually providing those services, computer services, and she's technically that's not part of her job. And I help throughout the agency fixing computer issues here and there, and it stops me from doing my financial work. And so there's a bunch of us who have small little things, and we have the county IT, and county IT does a wonderful job for us. They really do. If I call them, they come quickly. But having someone on staff and in the building to help us when we have issues with our electronic medical records or something's not working, to be able to train our staff on new programs, to be able to update us on things that are going on, would be very beneficial to us. Also, that person that I said that was the super user or the administrator for the EMR system, that person also does insurance credentialing. So back before when I said we were only had 3 insurances that we take, if that person's time is freed up, she can spend more time but trying to get credentialed with other insurances, which she does not have time to now, which can bring more business into the health department.
And just to add to what Tim said, and coming from the medical area, because in the long time, I'm looking at how can I upgrade the health system, because I don't think the health system may be the same place, because there are a lot of things that we can do in the health department for the clinicians to be able to have what they need to do their work. So in going in that direction, we may be able to have active person who can be able to help people to learn things that are in the health department. Because currently, when I ask people how to run Microsoft Excel or things like that, or even how to navigate things that I have, some of people don't have idea on it. So I think in my own looking at things that I would like for somebody to be on site to be able to assist them doing things like that. And then if we get Ryan White going, one of the things I would like to introduce going down the line, because I don't like to see the number of HIV in the county to go up. I would like to prevent it. And retention in care, HIV is a problem. So down the road, I will use Ryan White money to develop an app mobile app for HIV where they can use to remind them to take their medication to come for services. So IT positions could also be used to help in those. So there are a lot of things that down the road we are going to be doing in the health department, but we got to start from somewhere small, little by little, step by step, until we get to where we want.
It could even actually help with COVID vaccine scheduling,
Scheduling as well.
coming up with some sort of
Um,
workable solution
We
to
would,
easier scheduling.
we would not have any type of IT person without the approval of the county's IT. Because they would need to have access to do certain things for us, so it will have to be a shared responsibility. It's just would be someone, like DSS used to have someone housed in their area on site.
Yeah.
It would just be an on-site person in the health department. The electronic medical record system can be very daunting.
Yeah,
Especially when you have, all these signature pads that people are signing and, label makers and all this stuff, all of a sudden just stops working, and have someone on site who knows how to fix that stuff would be beneficial. to
Your
us.
employees also, the NCI administrator, supervisor, and that's the Immunization Registry. That's another piece that she has to make sure when we hire people that they get signed in and into the registry, and there's a lot of, our phones go down. Yeah, I mean,
Just this week. it went down
just this
twice.
week, we didn't have any phone contact with the outside world. And an IT person on site would have helped a lot.
But we would definitely work with IT with the county. We would definitely not.
We might have moved ahead of ourselves a little bit.
I think we do.
Let's talk about later.
That was a draft budget,
I know.
not submitted, right?
What about, department reports?
We have them. Well, you wanna do the COVID first?
Yeah, we can do the code first.
Okay, let me move so I can get near the microphone, so people need to hear me. So COVID cases, and of course, this only goes back, to January this year because I can't get them all on the same slide. When Mr. Caldwell was talking about us being in the orange and all the other counties around us, essentially to get us in a yellow state, which is a lesser state than moderate, we would have to have 35 or less cases in 2 weeks. That because of our population of being 34,000 and some change. So the only time on this graph that that's ever happened was a couple of weeks, because they do it by a 14-day increment. So March 15th and March 22nd, we actually have 12 and 13 cases those 2 weeks, but that's the only time. Our peak cases, new cases since all this started was 191 in a week. Right now, 41 new ones this week, but we're running an average of about 30 to 32 active cases. Because when we get new cases, other cases recovered, they get pulled off the active list. So that's, and our ratio to recovered and active are actually new case, that ratio is pretty tight right now, and hopefully it'll stay that way. We'll go to the next one. So the demographics, pretty much the same as they had the last time, males and females running neck and neck as far as infection rate. Black, African American, and white, their infection rates are pretty close. And, we have a large Native American population in Scotland County. And, I've seen an email that came through. I haven't had time to drill down and look at it, but Native Americans are also one of our under-vaccinated populations. And I don't know again if it is the stigma or the distrust of a vaccine. But Robinson County, of course, they have a huge population. So the bigger your population, you're gonna look under-vaccinated. But, we definitely are, we don't have a big Asian or Hispanic population, but, that and the black population are under-vaccinated in our county. And the next one, so this is our death summary, and you can see that the majority of the deaths are 70 and over, and mostly in male, and there's actually a few more white deaths versus black, but that's pretty much, and I had another one today. That would have been our 83rd fifth that I had to report today. And so here's our positives by zip code. So of course, Warrenburg, having the biggest population, is gonna have the 74%. Again, Laurel Hill coming in a big second there. And Marston actually has a lot of action, but it doesn't really show up on this graph compared to the rest of the population. That's kind of an interesting place, that Marston.
I know, we talked about that before, actually.
I see a lot of them over there. It just doesn't, that percentage compared to. And this next graph, I just sort of did this for funsies. So this is I graphed all our new cases from the very beginning of 2020 all the way till now. And those red arrows represent holidays. First red arrow is 4th of July. The next one is Thanksgiving, Christmas, New Year's, and then back at Easter. So you can see a correlation, a strong correlation between holidays and cases going up. And our cases are going up, the state's going up, nationally they're going up. And school just got out, back from their Easter break. They've gone back to their plan A, and they've got more students on campus. They've got 6 positive cases today
In schools?
in high school.
In the high school.
And Wakem had an issue last week, right?
Teenagers?
Yeah,
Or teachers?
It's teenagers,
Teenagers.
5 teenagers and 1 teacher. And I think there's gonna be another teacher. And they're not related cases.
Yeah.
They were exposed to family members,
Okay.
probably during the Easter break.
Yeah.
A lot of people think COVID is past us, but it's not.
No, it's not.
And
We don't have any phenotypes. We don't know if this is variants. do we?
No, so far, we have not had one in Scotland County that I know
Well, are we testing? You're not testing every patient for variants.
of.
How much of that are we doing? Not very much.
And
Nationally,
anybody-
they're not doing very much.
The hospital will be the one doing it, if anybody.
They're not doing it. If they
They're
are,
not doing any? They're not looking for the variant at
I
all?
don't think they have the capability to. I don't know who does. I mean,
Mhm.
England has much better.
Right. The genomic testing here is not too great.
So that could be Easter, or that could be the variants beginning to.
But it could be. We hope not.
It's a race between vaccines and variants is what it is.
Yeah, and I'm, like I said, 2 to 3 weeks usually after a holiday, hopefully we'll see it come down a little bit more. That's where we're at right now. And so total vaccines, I had to do a whole new slide deck for vaccines this time. This is the first time I've done this. Scotland County Health Department has administered 3,759. Now, that is to everyone, everywhere, not just Scotland County residents, just like, our residents have been to Moore County and Richmond County, they go everywhere. So these are the population that we have administered our 3,759 vaccines to. And this is first and second doses. And so as you can see, I think we need to, I've noticed a trend, the younger population is just not interested in this vaccine as much as they need to be, first of all. Females are more interested in males. And you can see that even when people wear masks out in public, when you start looking at the population, who's wearing them, who's not. I've got a husband who doesn't like to wear his mask, but yes, he does wear his mask when he's around me. I don't know what he does when he's not, but when he's with me, he wears it. And then with the populations as far as our race demographics, more white than black, Native American is next there, and then Hispanic, Asian, and other unknown. I forgot to put my N on my unknown. So that's the one. So then I break it down by where these people came from for these 3,759 doses. So mostly North Carolina, South Carolina, a couple from Michigan, one from Ohio, one from Pennsylvania. And moving on, now this is the ones that we've given for North Carolina residents and what counties they came from. So Scotland County, 2,863 is actually the number of people we vaccinated that are county residents. Then Robinson, way down there, but still the most. So you can see they came from a lot of places. Wake County, I don't know who the first would be, maybe Beaufort County. Yeah, they come from all over, and some people just said it, they traveled because they knew they could get it here. And then again, for our Scotland County resident demographics, vaccines administered. Again, you see the population is the older population, 60 and over, that are the most vaccinated out of our population we vaccinated. Again, females more than males, white more than black, more than American Indian, Native American. And so this is the percentage of Scotland County residents who vaccinated by race. So 2.9% of the black population, and then our American Indian, only 0.5% of our Native American population has been vaccinated.
So these are per capita percentages, right?
Mhm.
Okay, so the denominator is a number of whatever race.
Yeah.
Okay.
Yeah, so we've got some work to do on some of these populations for sure.
And that's just the health department.
Mm-hmm. Yeah, just what we vaccinated. Wait a minute, let me make sure now. No, this is everybody from Scotland County. Yeah, because I had to run that data from, I don't have access to other counties' vaccine, so I pulled it off from North Carolina DHHS, and they have all that.
So that includes the ones given by the hospital and
Mhm.
pharmacies and everything.
Absolutely. Wait, I lied, no, Dr. Carr, I lied. That is just the ones we gave. This
Okay.
next one is the one vaccinated by all providers. And there's, the blue is at least one dose, the red is fully vaccinated.
You're, 56% of white people and 42% of black people have been vaccinated. These are huge numbers.
Yeah, and the CDC said that we had, what, was it 60-some percent of
I got
the
a current
65 and
one.
older population?
Yeah, so the current one is here, 59.3%. 59.3% of population 65 years and older.
What was the number?
In Scotland County,
Yes,
in Scotland County.
59.3%.
Okay.
And I have that here, I can share with you.
And that's pretty good for that most
Yes.
at-risk population.
And this is the CDC data
Yeah, that's the CDC, that's the current one we have.
for Scotland County.
For
Well,
Scotland
they
County.
gotta get it from us or from the state, right?
Yeah, they get it from state.
Yeah.
So it says, yeah, the total vaccinated, fully vaccinated, 7,400. The percent of the population is 21.3%, is that right? And the percentage of population, 65 years or older is 59.3%.
So that's where I want people to look at, because that's the most vulnerable population. That's a significant milestone. I can share this with you after.
Yeah, and the other perspective I take is the people who are out working and moving around in our community that could carry the vaccine, which is that population of 25 to 50-ish to 60-ish. Their numbers are low in that age bracket. So we definitely need to work on reaching out to trying to get the trust of these other populations that don't seem to want to do it. That's all of my COVID. Anybody have any questions about COVID?
Nothing to do for it except what we're doing. And that's what I tell patients. And I think those of us who are involved in healthcare, those of us who are involved in local churches in the area, we need to be talking about that. I talk about that with at least 90% of my patients every day because they are this population right here. They're that population. And they're scared. They just don't understand. And so no one's really talked to them face to face. So I think for healthcare providers, it behooves us to take at least 60 seconds and mention, have you had your COVID vaccine? If the answer is no, try to see if you can kind of drill down and see why that is. And our churches, My church members are always asking about the COVID virus, and I think, and the COVID vaccine, and they're scared of the vaccine. So it behooves us to take time, because we meet before our church service every Sunday for 30 minutes. It's just a gathering. And so everybody asks questions at that time, and I'm always on for them to ask. And they know they can approach me and call me at home if they need to. But that's what it's going to take, our whole community coming together and trying to get those numbers down so they get those vaccines in arms.
And I will say that compared to, if you go to the North Carolina DHHS website and look at, their COVID dashboards, you'll see that as far as how we compare to our surrounding counties, we're above their percentage rates, except Moore County. The reason is Moore County's got tons of nursing homes that were vaccinated by a group coming in. So that
Yeah.
population, they're gonna have more vaccinated.
They're a pretty old county. I don't
Yeah,
think
there's
if
a
you
lot
take
of
their
old
average age.
population, retired people.
Yeah, and they would have higher numbers.
Hope County's not looking good at all right now. As
That's a
far
bunch
as,
of young people though, right?
Yeah.
Military and all that.
so,
I think I've shared my concerns with Ms. Caldwell and with you as well, Donna, and with Greg, at the hospital, and you all have started working towards trying to get in the community, and I do appreciate it. We talk about COVID all the time. I will tell you that a lot of our churches are opening up. I'm afraid that they are, but they are. I know a few churches will start back allowing in-person worship on the first Sunday of May. So I imagine numbers are gonna go up. But people are just not. I tried to do the vaccination clinic last Saturday at our church for a drive-through event. I had probably 25 people to show up actually wanting the vaccine, but I only had 5 who called in and reserved, sit up front, like I told you, that they actually wanted it. You know what I mean? So I think we do have to keep talking about it, trying to encourage people. There's just so much in the media that makes it really, really difficult to convince people. And a lot of people really feel like COVID is gone. With everything opening back up, they just kind of feel like it's not an issue anymore. And I think, I know we don't want to be too negative about it, but I think we've got to continue to spread the word that our numbers are rising, that COVID is still, a big
It's
issue
here.
in our community, and it's still here.
it's not going to go away, probably need to be booster shots.
Yeah, I had that argument with a nephew of mine yesterday, who is a high school student who just tested positive yesterday, works at Burger King, and I think there's something going on there. There are like 4 employees at Burger King who are positive, and, his thoughts were, well, I thought it was gone. No, it's not gone.
Are you suggesting that we set up a mobile clinic to go to the churches?
I do think that, which is what they've kind of talked about, I do think there's a need for, especially in our outlying communities of Gibson and Laurel Hill and those areas. I think we will have some benefit of showing up there with a vaccine clinic for those people who may not be able to get to town.
I think, to my knowledge, everybody's got a clinic that you gotta call ahead and make an appointment.
That's
Right.
right.
There ought to be some way that it's just a walk-in,
Sure.
drive-up clinic.
Yeah.
You might get more spontaneity. But I don't know what you're gonna do about the vaccine reluctance, because there's substantial reluctance. And when the country does this 6 out of 6 million,
Yeah,
and the
For Johnson & Johnson.
morbidity, mortality on the other side is much greater, they pull the vaccine. And you got to think they're in the pockets of the other
lose
two,
trust.
the competitors, they're in the pockets of Pfizer
Yeah.
and Moderna, and there's a lot of money corrupting the whole thing. They won't publicize a very inexpensive and safe medication that works to reduce morbidity and mortality, like ivermectin. They're just all over that. They won't talk about that.
That's right.
There's a lot of vested interests that are corrupting the whole thing,
So,
and then causing this fear. And I got the vaccine because it's a practical matter. I got to work in it. So, the lesser of evils, might as well get it. I'm old too, so.
I think that point that you made about, the appointments and that being the case everywhere,
Yeah.
I think, especially for younger people, if you get them convinced in that moment, it needs to be available, because if they have time to think of, then you lose them. So
They
I
don't take very long anyway.
That's right.
think, of course.
And they have to be scheduled is an issue. But now I will tell you what I did tell patients and what I tell people who ask me about the COVID virus, and that It is not going away. It will be here forever. We can't kill it. We can't blow it up. We can't burn it up. It will be here
It'll
forever.
mutate.
Yeah.
Forever. And, you know, then they kind of stick, because I think they really think it's going away.
Oh, yeah.
And it will never leave. And they need to understand that, and that is what I tell them. It's not going away. But if we could do any kind of drive-through clinic that didn't have to be scheduled anywhere, that would be fabulous.
Yeah, and one of the thoughts that I had about that, because the reason we have the schedule, there are scheduled clinics, is vaccine wastage.
Yeah.
Right.
That you're expected, you've got to thaw it and you have to take it. Now it's a 12-hour shelf life after you puncture it, so that's better than 6. So the life of it's double as far as your vials.
Yeah.
But the way I was thinking, and so, you know, when we do our clinics, if we decided we wanted to go out on a Wednesday or a Thursday morning, we know we've got vaccines scheduled that afternoon that are coming in to our clinic.
Yeah.
We go out that morning, take 100 doses, or however many we know we've got scheduled that afternoon. As long as we don't crack the vial, it's good.
Yeah.
Its shelf life is okay
Yeah.
as long as we keep it refrigerated. But if we don't give it, then we can give it to the people that afternoon that
That's
are
right.
scheduled to come in. So there's some flexibility there. It'll take a little planning to be able to advertise and say, we're gonna show up here. If
Uh-huh.
you want the vaccine, come by. And if we don't give off 50 or whatever we take,
You still have to
You
use
can
it.
give it
take it back
Yeah.
into the health department that afternoon.
Yeah, I just want to point out that the health education team has been working to send out vaccination toolkit to churches around. So they have built that toolkit, and those toolkits has been going out to churches just to give them information about the vaccine. And then with the help of the vaccination task force, we're going to be moving into that direction. And one of the things I would say is, even if we can give one dose, because both the mRNA vaccine has been proven to be 80% effective at one dose. So even if we can do one dose, and if the person comes there fine, they don't come back, well, that one dose is 80% effective, we can move in that direction. But the task force is going to be very important to give us idea on where we can go. That's why I want the task force to come together as soon as possible, and then we can move into that direction. But the health education team has put together the toolkit, and they're sending out to most of the churches around here, and that is ongoing.
There's another population too that have been overlooked, I think, and it's the homebound people that can't get out to get the vaccine. Not all of them have home health that comes in, and the home health agencies don't have the vaccine. So there's some work to be done there, because we've had a few people call and say, my mother's at home, she can't get out. But my suggestion is first, make sure people are coming in and vaccinated and being safe that are coming to see her. But we have a homebound population in this county that just can't get to the vaccine. And that's a work in progress there.
Yeah, so the homebound and the inmates are on the list. So, and that's what I have told the state, that I don't like the word historically marginalized, because the state is using that word, and I'm using the word underserved population, because there are people who are not historically marginalized, but they're underserved population. So that's what I said, the task force will be looking into all those things, that people who are homebound, people who cannot get to, the task force is going to look into those things and give recommendations, and then those recommendations will go to our clinical staff, who will then take the vaccine out. Like I said before, one dose of the vaccine is 80% effective. So if we can give one dose to people, like, for example, looking at it, because when I look at the inmates, now we were looking at whether we should use the Johnson & Johnson, because it's one shot, but then the Johnson & Johnson, until we can get a recommendation for CDC or FDA, we cannot use that right now.
Right.
So I'm looking into whether we can use the Pfizer or Moderna. If we can give one dose, and if we don't come by what, that one dose is 80% effective. So I'm looking at setting up the task force as soon as possible, and based off their recommendations, we can then turn over to our clinical staff to say this is what we're going to do. So, but that email went out today, and there is good responses.
Okay.
So we will start that as soon as next month.
And we have worked out, I called and spoke with Medical Village Pharmacy, and they're actually they had the Pfizer vaccine and they couldn't get rid of it either. They just can't get anybody to take it. So they're actually gonna vaccinate the inmates at the county jail.
They got 1,000 doses. 1,000 doses.
And we went out and did press weeks, first and second doses, and of course we did the schools first and second doses. We went to WEPAC a couple of weeks ago and, worked with Mount Calvary and did some vaccines on the WEPAC employees. And,
So how does the money flow? If Medical Village they get the 1,000 vaccine for nothing and they give them to people for free. Same thing here. So it's not like if you vaccinate 3,000, you get $100 a click or something.
No, it's.
I know it's all government paid for.
we do, at the health department, we do bill for an admin fee, but we can't bill for the actual cost of the vaccine, but we can bill for an administration fee. And insurance pays it. It can be a little bit of a pain because the patients come in to get their vaccine. Well, I was told it was free. You know, why am I having to, well, it'll never be a cost to the patient ever. It's just like any vaccine we give at the health department, we charge an administration fee for it.
So if you collect it, you collect it.
Yeah, and we put, how
But if
much
you
we
collect
collect
it, you may as well try to get it.
It's approaching $6,000.
Yeah, just for in the admin fees.
You may be the only ones billing it. I don't think the hospital is.
I don't think they are either, but you know, if you can collect it,
Good
and it
news.
is collectible, and you don't have to bill the patient, so it's only what's collected. If you don't collect it, you just don't, you just.
We have a general statute from the state that says you will take every avenue available to increase revenues. And when they send us that terminology, we have to
You
go.
don't have any choice, but you know, $6,000 is $6,000. So, let's just move ahead real quickly to, the departmental reports are in this report
Yeah.
here. So, is there anybody who needs to say anything about the departmental reports? Or can we, accept those as they're written?
I move that we accept them as written.
Okay, we'll accept those as written. Does anybody have any issue with that? Do I have a second?
Second.
A second on that, okay. So we'll accept those as written, and, if you would read through them, because there's a lot of things going on in the health department that we need to stay abreast of here. So is there any unfinished business we need to address? No? Moving on to new business, we, have a report from the Child Fatality, team. It's the, Child Fatality Team Annual Report that Ms. Carlotta Rivers has put together. And Ms. Rivers? She's going to present that.
Hello,
Hey,
can everyone hear me well?
speak up just a little bit louder.
Is this better?
It is, thank you.
Okay. Good evening, everyone. Ms. Chairperson, may I proceed with my report?
Yes. Yes, ma'am.
Okay, this is the Scotland County Child Fatality Prevention Team report for calendar year 2020. Also keep in mind that in 2020, the cases that we reviewed were child deaths from 2019. So the team is a multidisciplinary team that is composed of the Child Fatality Prevention Team and the Community Child Protection Team, which is staffed out of DSS. So we have different community agencies, of course, the health department, DSS, law enforcement, the school system, and other community agencies who make up this team. Our team, there's a mandatory 4 meetings that we have to have, but our team meets 5 times a year. If you could advance the slide, we meet 5 times a year in order to make sure if there's any overflow or if there are any cases that we need additional information on. We have the extra meeting reserved in case we need to do those cases for review, for a comprehensive review. After their review, they are sent to the local review coordinator from the state coordinator quarterly. She sends out releases of information to all the applicable healthcare facilities. We get the information back, and during every local meeting, each member asked to review information from their agency related to the case and present it to the group for discussion. have bring something cool.
Yeah.
If any recommendations made, is forwarded to the state coordinator, Ms. Brenda Edwards, and then it's sent further to the North Carolina Child Fatality Task Force. So in 2020, Scotland County combined team reviewed 8 child deaths. So 3 were under age 1. They were 19 weeks, 24 weeks, and 36 weeks. And the children's ages were age 4, 6, 14, 16, and 17.
Somebody on the way home.
Causes of death,
All right, bye.
newborn affected by premature rupture of membranes. 1 was congenital malformation. 1 was accidental poisoning by exposure to other drugs, medicines, and biological substances. 1 was intentional self-harm by firearm discharge. 1 was perinatal conditions. 1 was malignant neoplasms of primary multiple sites. 1 was by assault by firearm, and 1 was by unspecified acute upper respiratory and lower respiratory viral encephalitis and infantile cerebral palsy and cardiac arrest. So, with our recommendations, the majority of those were unmodifiable, but with the perinatal condition, there was although perinatal conditions was listed as the primary cause of death, there was a secondary influencing factor with that child was found on the couch with the father co-sleeping. So that was noted as a secondary reason. Our focal for 2020 was suicide prevention. Of course, our educational activity that we wanted to do in person was pretty much, we were unable to do that due to COVID-19 meeting restrictions. So our other activities involved me being the chairperson, sending a copy of the annual report to the County Board of Health in April of 2020, and I co-presented with April Sneed, the DSS director, to the Board of County Commissioners in May of 2020. Our suicide prevention billboard remains in place in Laurel Hill, right off of Highway 74. And our case review reports and the annual activity summary will be submitted by the due date of June 30th of this year. And it was sent in on June of last year. Any questions?
Thank you, Ms. Rivers. I don't think we have any questions.
Thank you.
Thank you. Okay, so if you'll look down at your agenda, the next item in new business is the review and approval of new positions.
Not sure exactly how much detail you want to go into. We just kind of covered that while ago.
Yeah.
Kind of, we got ahead of ourselves a little bit. But anytime we request a new position or anything like that, we do have to get the board's approval, to do so. Thank you, Shannon, for letting me know that, because we forgot that we haven't been doing that in the past, so.
I move we approve.
Is there a second?
Second,
Second, okay.
motion for
So moved. The next item on the agenda is the discussion of position reclassifications.
Yeah,
What is that exactly?
Do not discuss salary, just talk about the positions that you have up for the classification.
so I think there are 2, right? 2 reclassification. Do I call their names or no?
No, sir, don't call them that, just.
Right, so there's two reclassifications. I don't know how much detail you want for that one, but we do have 2 positions to be reclassified.
We have one that is a provider, a position extender 1, and a position extender 2. We want to move the physician center 1 to a 2.
That's, it's positions in the 2, 2 or 3.
2 or 3, I apologize.
Yeah.
It's a
These
2,
numbers
you
are
get
going
to-
up, they're going big, if the higher the number, the more credentialed they are.
Yes, sir.
Yeah, the more credentials they are, and
Yeah,
more
This person
More
based,
experience.
this
experience.
person based on their experience now is eligible to become a 3 and move from the 2.
And then health educator 2
Two.
to 3.
Yes,
And is more experienced that person is. So those are the two positions that we have to be reclassified.
Any more discussion needed?
I assume this is basically trying to give them a raise. Is that what the deal is?
which is a part of the budget that Tim,
Yeah, it's part of the budget that Tim discussed.
But basically, they are qualified to be,
They are
Reclassified,
qualified to be reclassified, and these are all based on recommendations and evaluations. And I saw the fit for them to be reclassified, and based on all those recommendations, and I think, and I made that decision to make a recommendation to the board.
we have a motion for that?
So moved.
Second.
Okay, we have a first and a second. All right, moving forward, the next thing on the agenda is the, blanket authority regarding, acceptance and immediately implementing any increase in the Medicaid reimbursement and so forth to increase the amount charged for vaccines and so forth and so on.
Basically, what this is
discussion about
this
that?
gives the authority of the health director to make fee changes before coming to the board. And since the board only meets by monthly now.
So move.
Here's a second.
Second.
Because it'll come to the board anyway.
Yes, sir.
It's
Yes,
just that
ma'am.
they can go ahead and put that in, because, we've been waiting, and I agree with that. So we've got a second on that.
Madam Chair, can we go back to, item D?
Okay, item D. Possible restructuring of the public health nurse 3, the child health coordinator position classification to a public health nurse 2.
You want me to explain this one?
Yes, please.
So our child health position is one that a nurse who is trained to become an enhanced role nurse. Takes about 6 to 8 months to get that certification, and then they can do real child physicals in our clinic. In the past, in the 16 or so years that I know of, we've had 3. They have to sign a contract, and if they leave before their contract 3 years is up, they reimburse the health department for what we paid to send them to school. Because it is time consuming and not cheap. But they don't usually stay in that role. They leave pretty quick after they get this certification. So when it's an actual working position, it has the potential to generate revenue. But we don't keep a nurse in that position. They leave. All 3 have. So what I would like to do, and this may take a little bit more investigation as far as revenue, if that's what you're concerned about, this PHN3 position, if we could hire a nurse as a PHN2 and train them, which is a lot less time, a lot less money, is more on-the-job mentoring type, to do postpartum and newborn home visits on Medicaid patients in our county. That's a revenue generator, and it takes a lot less time to train the nurses, and it's a lot easier to hire a nurse into a 2 position versus someone coming into that 3, they're reluctant to sign the contract.
Yeah.
And then when they actually do, they leave. So it hasn't been a very productive position, and it's been open for a while. How long has it been open, Sharon?
Wow.
We just can't feel it.
Over 30 days, and
It's been,
And before that.
8 months.
Before that was 7 months.
a combined total of, I would say, a year.
yeah, at least a year. So we just can't feel it. And we've interviewed that people will not take it for the salary, for one thing, and that they don't want to sign that contract.
Contract.
For the employment agreement.
Mhm.
So any further discussion on that to change that classification?
So just so we're clear, if you decide to do this, we would no longer have a child health clinic. We would pass through those funds to Purcell or as with our a contract with Purcell Clinic to doing well child visits or physicals that needed to be done for school or whatever.
I can't tell whether you're for this or against it. It's right
I'm
here.
for it.
I move we do what she
Absolutely.
wants.
Because there hasn't been anybody for a year.
Uh-huh.
It's just hard to recruit for that position.
And if you recruit, then you've got to train for 6 to 8 months, and then once they're trained, they leave. So basically, there hasn't been anyone for a while, so it would be more productive for the health department to have this position, to do these things, which they
And the
need.
state just says we have to assure
Yeah, and
these
the
services.
Purcell
We don't have to
Clinic.
provide them, we can assure them. With this money the feds give us, we can assure these kids go to Purcell Clinic
Yeah.
and we pay their bill for them.
For real child.
For real child. For
Uninsured.
Uninsured real child.
3 have left, they all reimbursed you?
Somewhat.
We've had one.
That reimbursed for the training.
Even though by contract they're supposed to reimburse?
Yes,
So can we take them to small claims court or large claim court or
that
whatever?
could be done through, what is it called, Tim? That,
Judge Judy?
no,
I don't know.
I forgot what it's called, but,
Yeah, one of them moved into a child health position in Robinson County. She used the training. She couldn't be an enhanced role nurse at the Robinson County as a school nurse, but the knowledge she was able to use, because it is a really good program if they ever.
and that's the
Well,
key.
say you gotta use every possible means to get revenue, and if people skipped out of town, didn't pay you back,
So
go after them.
Well, the average cost of Tentis training is probably about $3,500.
when I came in,
So, and when they take off and run after we spent $3,500, it ends up costing us.
Exactly.
so when I came in, I got a situation, and when we review when we review all the program, but the question is, if you are training somebody with the dollar, and then in the end, they actually don't stay and go, so, and you can't get the money back, it's costing the county more.
That's right.
Whether you have a program where you spend less money training, but then the person stay.
And
So,
you get revenue from it.
and then you generate revenue. And like I said before, in order to be able to push the revenue for the next 5 years, we gotta figure out which program we can invest in more and can generate. So I suggest to them that, based on their recommendation, to recommend to the board that we should make a change instead of.
So we have a recommendation for a change, in this position. Do I hear a motion for that?
So moved.
Or is it a second? Okay, we have a second, so we'll move ahead with that.
Thank you.
In the future, there may become a time when there might be somebody else eligible for that, the well child checks and so forth, so, keep it in the back of your mind. Where we talked about the blanket authority, we approved that. Okay, next on the agenda is the approval of the new HIV labs, and they are attached to your agenda. If you want to glance at it real quick, is there any discussion on that?
Move we approve.
Okay, is there a second?
Second.
Second.
Okay.
Madam Chairman,
Question?
let me just, I've said in a lot of meetings, if we have a second, then we have to vote on it. I'm just gonna say, by consensus, everything's been unanimous tonight, right? But we haven't really had a vote.
It has been.
You understand what I'm saying?
Yeah.
We haven't really, you haven't said, all in favor say aye, all opposed say no.
Okay. Do we want to just take everything as a group right now, since it has been unanimous?
Sure.
Okay. All right, that's all
That
we
would
need.
help me with the minutes, thank you.
Okay, Wood, all
Yes.
right. All in favor of everything we've discussed on Tuesday? Aye. Okay, good. Okay, Terry, you got it.
I noticed that too, but I.
Just went through that one, okay? Okay. So the HIV labs and the additional funding,
Yes. Which one is?
you talked about that earlier, I think.
Yes, ma'am.
I thought we already voted
So
to.
that's already been addressed.
Yeah.
Okay, is there any further discussion?
I did need a motion to accept all those funding and the second, has to be.
Is this the kind of thing that's gonna be automatic in the future? Didn't we just pass something that said like all this stuff, all these fee increases are gonna be automatic in the future?
Yes.
But is this?
It still needs to be
It's still
brought
gotta
before
be
the board.
brought
Yeah, we'll bring it to the board.
It'll come before
Yeah,
the
we'll
board.
come-
But you can approve it before.
I can approve it and then,
Yeah, anything.
So moved.
Okay.
I will approve it, but
Second.
All in favor?
Aye. Opposed? No.
Okay. You can't vote twice. Is there anything else? Any other discussion? All right. Somebody like to make a motion to adjourn?
I move to adjourn.
All right.
Usually that Thomas.
Nay.
I know, we usually have a motion. Okay? All right, you can stay.
This guy ran for office, he like, meet me.
No.